So tonight's topic is the topic of polycystic liver disease, commonly known as PLD. This affects many of our PKD, polycystic kidney disease patients, although it can be found in isolation, something that I imagine we will talk about when we go to our presentation. So I did introduce myself sneakily there. I am Susan Muirhead, the Support Services Manager here at PKD Charity. On the call tonight, helping me in the background, we have our CEO, Alison Taylor. Good evening, Alison.
Good evening, everybody.
And our guest speaker tonight is Dr. Aarathi, and she's a clinical fellow in the Liver Transplant Surgery Unit over at Leeds, St James's University Hospital. I couldn't think of the name of the hospital there, so it's at St James's. So just a little bit of additional information about up-and-coming events that you may not be aware of. Here in the UK, we do like to do some in-person events. So our next in-person patient information and support day has been held in September, and that has been held down in Cambridge. Booking's now available for it, and the feedback we receive from these is always fantastic. It's a full day event, and there's many talks and workshops planned for that. I'm sure Alison will pop the link into the chat for that. You may also have heard we have PKD Connect groups. These groups are fun and informal. They're support groups, but we sit, chat and have a cuppa. Occasionally a cake sneaks onto the table as well. They're a lovely place where you can share your PKD experience, whether you're a patient or a loved one and family member. I know myself, I'm a PKD wife, and they're a great opportunity for me to share and learn. I've highlighted there, we have an upcoming one in Dorset at the weekend. It's a brand new meeting for the Dorset area, and I've listed some others that are happening this month. Again, if you want to hear any of these events, have a look at our website and see what's happening near you. I think in totality, we're hitting almost 20 groups in total. Some meet online and other meet regionally. Don't worry if you're in Scotland, we've got 2 new ones coming soon for Scotland. Just for those who haven't joined us for a webinar, you'll see on your screen just now how to ask questions. Down at the bottom, you'll see a little Q&A circled in green. You can pop onto that and you can type your question into the chat. At the end of tonight's presentation, Alison and myself will go through there and we'll ask questions. However, where possible, keep your questions to the topic of PLD. We do struggle for time. And I have to give the medical disclaimer. We have one doctor in the house tonight. Unfortunately, we cannot give individual medical advice. This webinar is for information purposes only, and it's not a substitute for any professional medical advice or examination. As always, consult with your doctor, your pharmacist, or any other medical professional if you have concerns about your care or before taking any treatment. And again, we can't promote any specific brand or recommend any treatments, etc. Now, what I'd like to do is hand over to Dr. Aarathi now, and she will take you through understanding polycystic liver disease. You can give us one moment, we'll just swap over who's screen sharing. I see some of you are on the ball already. There's stuff appearing in that chat. It's Alison with the information there. If you're not sure about chat, if you the side of your screen, you'll see it there.
All right.
That's perfect. That's you through now.
Are you able to see my screen, Susan?
Yes, we're seeing it in full display. Thanks.
Fantastic. So before I proceed, I would just like to thank Susan and Alison for this kind invitation. For the benefit of everybody, my name is Aarathi. I am a doctor. I work as a clinical fellow at the liver unit at Leeds at the St. James's Teaching Hospital. What we're going to do today is sort of try and demystify polycystic liver disease for all of you. For several reasons, mostly because polycystic liver disease is a very, very rare condition, much rarer than polycystic kidney disease. So before I proceed, let me just walk you through the structure of this talk today. We'll begin by trying to understand what causes polycystic liver disease. We'll then go ahead and try and understand what patients feel, what their symptoms and some of the complications they encounter during the disease progression are. And then we'll also have an overview of the several management strategies, including lifestyle modifications, non-surgical strategies, and finally surgery, including how to navigate the UK transplant system for polycystic liver disease. So trying to understand a little bit about what causes polycystic liver disease. First of all, like I said, polycystic liver disease is extremely rare. Cysts in the liver, in fact, is one of the most common things that can occur, and they are more common in women. These cysts can occur in isolation or they can occur in combination with polycystic kidney disease. So what gives rise to cysts in the liver? So cysts arise from the lining of the small bile ducts within the liver. These bile ducts, they're called cholangiocytes. And these cells have their normal function. These cells have cellular extensions which help the cells function normally. But when there is some genetic disorder because of which these extensions dysfunction, what happens is these tiny cells, they tend to separate from the main ductal system and they sort of become separate and they start secreting fluid within themselves and then inflate, giving rise to cysts, as you can see in this picture. And like I said earlier, they can occur in isolation. And by that, I mean only cysts in the liver, or they can occur in combination with cysts in the kidneys. It's extremely rare. And talking about cysts occurring in the context of polycystic kidney disease, it's one of the most common extrarenal manifestation of patients who've got cysts in the kidneys. And these occur because of specific genetic mutations. So what is a risk factor for polycystic liver disease? Studies, and oftentimes we see that in clinical practice, women are the most commonly affected. And this is because there is very distinct difference in genetics and hormones between males and females. Liver cysts have been found to be extremely sensitive to estrogen, and estrogen is known to stimulate the growth of these cysts and they lead to their multiplication. The effect of the other female hormones are not fully known, simply because it's very hard to learn the effect of each female hormone or each male hormone in isolation, because they never occur in the body in isolation. But some animal studies have shown that estrogen has the highest impact on the growth of these cysts. And we have also seen that in several women, the volume of the liver and the size of the cysts, they tend to reduce after menopause. If you can look at this graph over here in the top right corner, between the ages of 45 to 55, when women approach menopause, and later, you see that the size of the cysts in these patients and sort of the total liver volume in patients with polycystic liver disease, they tend to reduce. So there is a general recommendation to avoid using estrogen-containing oral contraceptives in patients who have polycystic liver disease. So what happens at initial presentation? Usually, someone who may have polycystic liver disease, they usually don't have any specific symptoms. They have generalized fatigue, they've got vague abdominal pain, and they go to their GP. And as anybody would do, they do blood tests. And what happens is that liver functions come back normal, which can be quite surprising and invalidating for several patients because they continue to feel incredibly unwell. And this is the great paradox of polycystic liver disease, where you've got this condition in the liver with multiple cysts causing extreme discomfort to patients. But the liver functions, the clotting of the blood, the clearing of toxins from the blood, all of that is normal. So basically, you've got perfect blood tests, but a failing body and increasing number of symptoms. This happens because the native liver tissue in patients with polycystic liver disease is actually healthy. The liver cells, they are perfectly functioning and doing their job. But it's the space that the entire liver, by virtue of being filled with cysts and fluid, that is the real disease. So what are some of the symptoms that patients have? So the symptoms of polycystic liver disease, like I said earlier, is mostly because of the mass effect of the huge liver and the cysts and the fluid that it contains. So one of the organs and the most common organ that these cysts tend to impact is the stomach, because it is the closest to the liver. So what happens is the cysts, they compress the liver. So oftentimes we see patients who come to us and say, I've had 2 bites of food and I feel completely full. So what this leads to is early satiety, very severe acid reflux. You go to bed, you wake up in the night and you feel severe acid reflux because the heavy liver is compressing on the stomach and the bottom end of your food pipe, causing acid within the stomach to reflux and cause the pain. Early satiety also means you're not eating as much as you should, which then leads to very unintentional and unfortunate weight loss. What then happens is, even though you're losing weight, you've got this very full-bellied appearance because of the increasing size of the liver. And oftentimes, patients come to us and say, I was walking down the aisle in a supermarket and I was asked if I was pregnant. This can also impact mental health in several patients. And what really is happening is there's hidden sarcopenia. Sarcopenia means loss of muscle tissue. But then you've still got a full belly and you don't look as unhealthy as someone who's as ill in terms of symptoms that you would feel. And you'd continue to have increasing fatigue and tiredness. Beyond the effects of the huge liver on the stomach, there are other symptoms patients can present with. So liver sits at the top of your belly on the right side, which is very close to the diaphragm. So as you know, when you breathe deeply, the diaphragm moves down, and that's how you are sufficiently able to inspire air. When the liver increases in size, it presses on your diaphragm, and then you feel that you're unable to breathe fully, and you over time develop shortness of breath. There are also several blood vessels that travel from the lower aspect of your body through the liver and back into your heart, so that the heart can pump the blood back to the rest of your body. So this blood also starts to well up in the bottom end of your body because they're not able to go through the liver because of the pressure within it. And this over time can also lead to swelling in your legs. All the symptoms that I've told you so far, they develop gradually over time. It's never sudden, but there are still some sudden symptoms that patients can feel. And this is usually when there is any infection in the liver, or for some reason there is spontaneous bleeding within the cysts. So this can present as very sudden pain in the right upper aspect of your tummy. And you can also have very high fevers or rigors, which may indicate infection. Some of the other complications are having back pain. So what happens is when you've got this huge liver, you over time tend to change the way you walk, and that can lead to pressure on your spine and lead to lower back pain. And patients also tend to use increasing painkillers over time. And what all of this means is that the quality of life of these patients is gradually reducing over time. Apart from these complications, sometimes the cysts in the liver can compress some vital structures within the liver. So liver is an extremely vascular organ and with a lot of important structures within it. So when these vascular structures are compressed by the high pressure cysts within the liver, that can again lead to complications within the liver itself. So how do we manage polycystic liver disease? The primary aim of managing polycystic liver disease is to try and mitigate the mass effect. And how can we reduce the liver volume? How can we make sure that patients who got this compression on the stomach are still able to eat and maintain their nutrition? So the primary focus of non-surgical management is to improve nutrition, and that is by consuming high protein and calorie dense diet. It becomes very hard for patients to eat 3 large meals in a day. So it's often recommended that they have small 5 to 6 meals in a day so that the mass effect of the cyst on the liver does not impact their eating habits. It's very useful to involve a dietitian from early on, because externally, when you're helped in terms of sort of monitoring your weight and other nutritional parameters, we have often seen improved outcomes in these patients. Coming to medical management, what happens when you try to manage with your lifestyle changes, but still the cysts are continuing to increase and cause symptoms? So there are medicines that can be given, injections, which the doctors can prescribe you. What these injections do is they suppress the growth hormone. So all these cysts have receptors for growth hormone on the walls, and giving these injections can block these cysts, and over time reduce the quantity of fluid that these cysts secrete, and it can stall growth, and over time reduce the size of these cysts, although these medications cannot cure the cysts completely. So when lifestyle and medications fail, then we have to look at surgical options. So there are various surgical options that we can look at in the management of polycystic liver disease. I'm sorry, I think we've lost some of the slides. If you can just give me 1 second, Susan, let me just go back and see what's happened there.
Not a bother at all.
Are you able to see the slides now?
Yes, you're in slide 18, and then you've went to your final one, which is the
Yeah.
takeaway.
That's very odd. So I'm just going to come off the slideshow if that's okay, because I think I can still see the slides here. Are you able to see the slides now?
Yes, we're certainly seeing them at the moment. The one that you're showing is this surgical escalation pathway with your 4 arrows along the center.
Yeah. So like I said, when lifestyle modifications and medications fail, what we do is we explore surgical strategies. So one of the first things that we can do is sclerotherapy. So as I said earlier, these cysts have fluid. So what we can do is we can insert a needle under the guidance of an image, which can either be an ultrasound or a CT scan, aspirates the fluid out, and then inject a certain type of medication, which can then obliterate the lining of the cyst. What this does is it will prevent the fluid accumulation in theory, but we have often found that there is a high recurrence rate in these patients, and therefore we reserve this particular method only for patients who are not able to tolerate other kinds of surgery or who develop some local complications. If we have attempted this technique in patients, then what we do ideally do is follow it up with a more definitive form of management like cyst fenestration, which we'll talk about next. So cyst fenestration is a surgical technique where which oftentimes we're actually doing it minimally invasive, which is basically keyhole operation. We make small cuts to your tummy, we insert instruments, and then we visualize the liver, we identify the cyst. And what we really do is decapitate the cyst. So by that, I mean, we remove a portion of the wall of the cyst and then drain the fluid within it. Because we've removed a portion of the wall of the cyst, the fluid is no longer able to accumulate, and the lining of your abdomen is able to absorb this fluid into the circulation. So by this, the cysts, they tend not to reaccumulate and cause the pressure effects. So these are typically performed if you've got multiple large cysts which are causing symptoms to patients. The next technique would be removing the cyst and a portion of the liver itself. So we discussed removing a portion of the wall of the cyst. Now we are talking about removing a portion of the liver. In polycystic liver disease, you will find cysts across the liver. usually it's the left side of the liver that's putting the pressure on the stomach. So if that is the case, and you've got some good amount of liver tissue otherwise to sustain your bodily function, then we can remove a portion of your liver, which is causing the pressure on the stomach. And this can be performed by keyhole operations or an open technique, which is, by that I mean cutting your abdomen open. And this is also known to relieve several of the symptoms of patients. So far we spoke about techniques that reduce the size of the liver, but it does not really cure polycystic liver disease. The only curative option is liver transplantation. By that I mean removing the liver which has got the multiple cysts and putting a new liver in which has got no cysts. And we've done over 100 transplantations for polycystic liver disease in the country, and most patients have excellent survival at 1 year of 93%. And we've also seen that patients at 5 years who get transplanted for polycystic liver disease, they do significantly better than patients who are transplanted for non-polycystic liver indications, such as, let's say, cirrhosis or cancer. The caveat to this is that polycystic liver disease is listed as a variant syndrome within the transplant system. And by that, I mean that because the liver function is normal, whether or not you get listed for a transplant depends hugely on the symptoms you've got and not necessarily the liver function. Because of this, because polycystic liver disease patients are not necessarily prioritized, we have seen that patients often wait 3 times longer to get a liver. And if we are planning a combined liver and kidney transplantation, essentially in patients who've got polycystic kidney disease as well and renal failure as a result, those patients tend to wait for much longer than patients who are only waiting for a liver, because you are not waiting for just one organ to be matched to you, but 2. So the way the transplant system works is that if 10 patients are getting transplanted, 9 of them are usually transplanted for cirrhosis or cancer, and 1 liver goes to the variant syndrome patient, and one of those indications is polycystic liver. So the allocation is not necessarily symptom-based, unfortunately, at the moment, and is more proportional. And that's why the waiting time for liver transplantation for these patients is much longer. So I'd like to conclude by just highlighting a few points. The polycystic liver disease causes symptoms due to the enlargement of the liver and not necessarily loss of function. And patients often feel very unwell despite completely normal blood tests. And the treatment strategy that we often follow is a very stepwise approach, starting from lifestyle modification, giving medications to stall the growth of the cysts, perhaps trying a few surgical techniques before finally attempting transplant only in those patients who got intractable symptoms. Unfortunately, like I said earlier, patients with polycystic liver disease wait much longer for a transplant because the indication is proportional and not symptom-based at the moment. Thank you very much, and we're happy to take any questions you may have.
Thank you for such an informative presentation. And I see the hot potato and the questions that are coming in are hormones. So I will start just in the order they came in. And I think the one from P came in before you actually covered that in a slide. How does taking HRT affect the development of polycystic liver disease?
So, like I said, estrogen is the primary driver for the growth of these cysts. But that is not to say that not taking them will cure these cysts. So, if anybody has to be on hormone replacement therapy, they need to be continuously monitored, usually by annual scans, to make sure that if they do have cysts, they're not alarmingly increasing in size.
And that almost answers one that Amy's asked in there. Is there another way to manage menopausal symptoms? Does testosterone also create a problem?
So at the moment, we do not have any evidence to suggest that testosterone causes increase in the growth of the cysts. Again, menopausal symptoms will have to be managed without HRT. That will again have to be lifestyle modifications. But using HRT is not a contraindication. All we have to do is, if you are on HRT, to be monitored by your GP or a specialist with scans from time to time to make sure these cysts are not growing alarmingly in size.
So I think it comes down to common sense to be aware that you are taking a hormone and it has a risk factor. But we know for many of our community, the risk factors outweighed by the benefit of that treatment. And again, Elizabeth's asking, is a surgical menopause an option for females who are perimenopausal?
Yes and no, because once with surgical menopause, again, the impact of estrogen and other hormones is very variable. In some patients, even HRT does not cause any change in the size of the cyst, whereas in other patients, despite stopping HRT, the cysts continue to grow. So I think surgical menopause is probably a bit of an overkill because we've got other strategies to manage patients with polycystic liver disease.
That's super. I'll move on to another topic. I think we could be here all night talking about hormones and the effect of it. So what I'd like to do is, Elizabeth's asking, how do we get the right protein balance if we have PKD? And she doesn't quite understand the benefits of perhaps a slightly lower protein diet.
Yeah. So I think if you are on a low protein diet, what you can do is you can still consume calorie dense diet, which will give you good amount of carbohydrates and fats, while still maintaining on a low protein diet and engaging in physical activity that will help your muscles grow. So protein is not the only thing that will cause your muscles to grow. If you put your muscles to work, like going to the gym, doing physical activities that stimulate your muscle to grow, that can also lead to growth of muscle. So if you are on a low protein diet, what I would suggest is work with a dietitian to continue consuming calorie dense, high carb, high fat diet while you're engaging in other physical activities to build your muscle.
Someone just, when we're talking about diet, has asked, should they stop eating phytoestrogen rich foods such as tofu when they have PLD?
We don't so far have any evidence to suggest that phytoestrogens stimulate the growth of liver cysts. So unless we have fresh evidence of that in science, that is not recommended. Tofu is high in protein, so I wouldn't necessarily avoid that as part of my diet.
Right. Before we move on to the topic of treatments and medications, someone's asking the best way to manage indigestion and acid reflux symptoms that they're experiencing.
So one of the things you can do is make sure that if you've got polycystic liver disease and you've got these indigestion symptoms, try and eat smaller meals and make sure you're eating at least 3 hours before you're going to bed. And try and keep yourself slightly propped up so that the reflux is not as severe as it would be if you were lying all the way down. And if you go to your GP, they can prescribe you some medication for anti-reflux and reducing the production of acid in your stomach. So a couple of these things can help mitigate your symptoms.
And the final question at the moment on the kind of diet food aspects, someone's asking, are there any foods that can aggravate the cysts at all?
No, we don't really know if any particular food will aggravate these cysts. Although one thing I would like to mention is that because you've got cysts in your liver, even though the remaining cells are normal, one of the things you should be careful about is consuming alcohol in moderation. That is one of the things I would recommend everybody to be a bit cautious about.
That's perfect, because in the chat, what effect does alcohol have on PLD patients with normal function? So when we say moderation within, what is moderation? I think we all forget.
Yeah. So I think we've got guidelines for that in the UK. Men and women should not consume ideally more than 14 units of alcohol per week. So, that amounts to certain amounts of alcohol, and not exceeding that every week will be helpful. But again, it's very variable because some livers are more prone to be affected by alcohol than others. So there's no way to really know why and how, because it's not just alcohol, but also perhaps if you've got diabetes, all of that factors can act together in injuring your liver. So it would really depend on multiple factors, but I would suggest following the guidelines at the moment, which is consuming less than 14 units of alcohol per week for all adults.
That is fantastic. Can we go to symptoms, I think, before treatment? What do you think there, Alison?
Yes, we could do that.
Yeah. Now, just a nice starter question. Do you sometimes get a loss of liver function with PLD?
Yes, that is a very good question. So most patients have normal liver function, but like I said, liver is a vital organ. It's got a lot of important vital structures within it, such as bile ducts. So if the cysts are compressing any of these vital structures, then you can have abnormality in liver function. So some of the liver enzymes can go up because the cysts are compressing your bile duct. So you can still have loss of liver function, but it is rare.
Someone else is asking, how many cysts would be a lot? They've been told they have around 200 by ultrasound and MRI. Now, in this question, I haven't stated if it's polycystic liver cysts or kidney cysts, so we'll keep to the topic of liver tonight.
Yeah. So from a clinical point of view, we don't quantify cysts by number. We quantify them by symptoms. So if you've got a certain number of cysts and they're not causing any symptoms, that's great. But if you have lesser number of cysts, but they are bigger in size and therefore causing symptoms, that's probably cause for worry. So I wouldn't go by the number of cysts, but by the impact that those cysts are having on your symptoms. Having said that, we call anything above 20 cysts in the liver as polycystic.
That is fantastic. And I think we have to hit on some of the treatments that you mentioned and different bits and bobs. Alison, have you had a little chance to look through?
Yes,
Thanks.
I've been looking. There's a couple of really interesting questions. Somebody's asking, how many times can you undergo fenestration? Fenestration safely, and it still be okay for a transplant in the future?
So the answer is as many times as the surgeon thinks they can get access to the liver. What happens is once you've had a cyst fenestration, we have oftentimes had patients go back for fenestration twice, thrice, and then still have a transplant much later. Fenestration is usually reserved for patients who've got large cysts. What happens in polycystic is you've got multiple smaller cysts, in which case fenestration, we may attempt once, perhaps twice, but we may not engage in that form of therapy more number of times than that if we think it's not benefiting you.
Mm-hmm. Now,
Thank you.
Lovely question there from Helen. Can I have treatments, injections, etc., having had a kidney transplant 13 years ago?
Yes, you can. As long as you're under the follow-up of a nephrologist for your kidney functions, you can have treatment with injections.
Super. Just talking about fenestration, one's caught my eye. Can it be used for cysts in the kidneys?
I'm not an expert on kidneys, but I think they can be used. But I think perhaps we should wait on that, and maybe we can get back on that answer tomorrow once I've had a check with one of my colleagues, if that's okay.
That's great.
Lovely. And thank you for that sensible response.
Thanks. Somebody's asking about esophageal varices due to portal hypertension and whether you can sort of shed any light on that or information around that. They must have been told that they have that as part of their polycystic liver disease, I presume.
So if they've got esophageal varices and portal hypertension, it probably means they've got cirrhosis, which again, in a patient with polycystic liver disease is extremely rare because, like I said, the underlying liver tissue, the cells are normal. So I suspect this particular patient may not necessarily have polycystic.
Right.
Yeah, so
Okay. Thank you.
but I would suggest this patient to definitely go to the hospital if they haven't already. Not hospital, but to go to their GP and get their liver checked.
Thank you.
And again, pain and discomfort. If you're experiencing pain and discomfort, should you attend a liver clinic?
If you've got pain and discomfort and you know you've got cysts in your liver, then I would definitely suggest going to the GP to get a scan so that you can see if there are any large cysts that we can drain for you with either fenestration or any other form of surgery to relieve you of the symptoms. At least to get that one scan to see if there's a big cyst that we can drain.
Someone's mentioned the common pain linkage that we tend to find in the community. When there is a flare-up, can a pain in the neck and shoulders be due to PLD?
Usually, if it is on the right side and you've got pain on the shoulder, that can be from having a large liver, but it's usually combined with pain in the right side and the right shoulder. But it can still occur in isolation because of a large liver, because of, we call it referred pain. Basically, these two areas, they've got similar nerves supplying them. So you can still have pain in the shoulder from an enlarged liver. So to answer your question, yes, that is possible.
Right. We've spoken about liver resections. When a liver resection is done, does it grow back with or without cysts?
So when we do liver resection for patients with polycystic liver disease, we oftentimes try to make sure that you've got normal liver functions, you've got good amount of otherwise normal looking tissue that can help you sustain your bodily function. So these are things that we often rule out before we consider liver resection for patients. So if I go back to, I don't know if you can see it just yet, but the picture, is my screen still sharing?
Yes,
Yeah.
you're showing the resection slide
Yes,
there.
so the resection side, if you can see here at the back of the liver, there's still some amount of normal tissue, which is why we were, in this case, we were able to still remove a portion of the left side of your liver. That's because we could bank on the normal amount of liver to work for you. So this will really depend on how extensive the cysts are in your liver. So a scan will tell us if there's any normal liver tissue that's there, which if it is there, then we can attempt liver resection.
Yes. One of the questions that came in earlier, I think it was one of the first or second questions to come through, is relating to our treatment. And this person's mentioning that they've been told that octreotide is only suitable for the early stages of PLD and the side effects outweigh any benefits when PLD is more progressed. Is that something you'd be in agreement with?
Yes. So I think, first of all, octreotide is an injection you will have to give 3 times a day. But there are other forms of octreotide which we can give as monthly injections. And yes, if they've already developed cysts which are extensive within the liver, it is possible that in his case, the risks may outweigh benefits because octreotide can slow down your bowel, can lead to malabsorption. So in patients who already have nutritional deficiencies, giving octreotide can further compromise their nutrition.
Thank you so much. Alison, is there anything that's catching your eye in the chat that's just so busy there with questions at the moment?
There's so many, and there's more coming in all the time. Somebody's asked, if a parent has PKD and PLD, are there children who also have PKD destined to get PLD?
So inheriting PKD does not necessarily mean you will also develop PLD. You may have cysts in the liver, but the rate of their growth and the natural progression of the liver disease can be different between patients and can be different between parent and child, can be different between siblings. So
Okay,
you're not necessarily destined to have polycystic liver disease, which will become symptomatic and you will need treatment for it later. Not necessarily. But you will need at least a certain period of perhaps monitoring to just make sure that the cysts are not growing extensively.
Okay.
Lovely. And we're hitting out. I'm going to move us on to transplantation. Then we can come back if we have time for some of the other bits and pieces that have come in there. Someone's asking, what effect has the review of liver transplant allocation scheme had in the waiting list for PLD patients? The person understands that the waiting list is likely to become even longer as a result.
So we don't definitely know that yet, but we do know that patients were already waiting a considerable period of time, and they will continue to wait a considerable period of time. Previously, the allocation worked differently. So if there was a liver close to a transplant center, it went to that particular transplant center. And if there were patients with polycystic liver disease in that unit, the surgeons had the discretion to choose them for the transplant based on their symptoms and the severity of their symptoms. But right now, it is offered nationally. And so the allocation pathway has changed, but I would agree that it has not necessarily benefited polycystic liver disease patients, but we do not yet have definitive evidence of that yet.
Mm-hmm. Question that comes up when we talk about kidney transplants, and I've got a feeling the answer might be the same when we talk about liver transplants. After liver transplants, will the cysts still grow?
No. So when you have a liver transplant, your native liver, which had the cysts, have now gone, and you've got a completely new liver, so you will not develop new cysts unless the new liver had cysts, which is unlikely.
And a lovely comment, right? And it sounds so simple here. I've also been told that once a huge liver is taken out, it's easier to plumb a new one back in because all the space it's been created.
It is true.
Yeah.
We've had livers that weigh 15 and 16 kilograms. And so, yeah, there definitely is a lot of space to plug a new one in.
Is there anything else catching your eye about transplantations? There's one that's caught mine there, and it's about the growth of cysts. Will the cysts keep growing forever? Specifically, if there's more room, for instance, if you had your native kidneys removed due to the sheer size of your tummy.
So the cysts don't grow because they have space, they grow despite not having space. So that removing cysts or removing kidneys which have got cysts does not necessarily mean that the cysts in your liver will grow. Having said that, it is in the natural history of these cysts to continue to grow and progress and increase in size over time. But again, we do see that in a lot of patients after menopause, the rate of growth of the cysts does reduce.
Something we hadn't touched on. What are the symptoms of a burst liver cyst?
So I think, yes,
when to talk about the treatment with antibiotics, etc.
Yes. So I think we spoke about infection of the cyst. We spoke about bleeding into the cyst. We didn't really talk about a cyst bursting, which would present quite similarly to having an infected cyst or a cyst which had bleeding. You would have sudden pain, and which can sometimes be a bit generalized. That can then lead to a bit of infection, which will need to be treated with antibiotics and painkillers. And you may have to be in the hospital for that.
Yeah. And you mentioned earlier about the weight of some of the livers you've removed.
Yeah.
Someone's mentioned here, my liver now weighs 26 pounds and they've been listed for 1 year already, waiting on a transplant. Will it just keep getting bigger, and will they end up unable to walk as they're struggling to now?
So unfortunately, the cysts do continue to grow, but you're on the waiting list, which is a good sign. You've already waited a year, which probably means the time you have to wait will hopefully only be shorter than someone who's not on the list yet. So I wish you all the best, and I hope you get offered a liver very soon. But you should maintain good physical activity, try and eat as healthy as you can so that we can mitigate the other impact that polycystic liver has on your body, so that you can be as fit as you can as you go into your transplant.
Thank you so much for that. Someone's asking, should you get offered a cadaver kidney? Are the chances of getting a liver from the same donor affected by the allocation system, or does a cadaver kidney transplant, is it considered separately? Because we know it's not often a dual transplant takes place at the same time in the UK.
Yeah. So a dual combined transplant, both the organs will come from the same donor. So the new allocation system does not necessarily change that. So the matching is we try and be more accurate with the matching of the kidney rather than the liver, because with the liver, all you have to match is the blood group. But with the kidney, there are a few other things that you have to match.
One it comes up fairly frequently is BMI. Is there a BMI cutoff for liver transplant? And when we calculate BMI, is there allowance for the kidney volume? Is it factored in?
At the moment, we do not factor in the volume of the kidney necessarily, but we do struggle to list anybody who may be morbidly obese with a BMI of, let's say, over 45 and 50. But we have transplanted patients with BMI as high as 40.
Mm-hmm. Now, I'm just going to run down randomly. We've only got 12 minutes left of your time tonight, and I really appreciate you giving it up, and I don't want to keep you any longer than necessary. Questions are still coming in fast and furious. I'm aware there's 21 questions still in the chat here. Some we know have been covered, but we'll look at other ones as well. Something we hear all too often in the helpline, and someone's put it in here. Why does my liver care for PKD just focus on my kidneys and my liver is ignored?
So it's possible that you've got cysts, but they're not big enough to warrant continuous monitoring. Mm-hmm. Or perhaps there aren't any cysts in the liver. Is the question, does this particular patient have cysts in the liver as well, Susan?
They haven't said in the question if they do have them. Yeah. Potentially, I know a family member who's been told there is liver cysts, but we know that there's no huge enlargement or symptoms. Yeah. But I know that was one that's come up there. The person hasn't said. If they want to pop another question in, expanding on it, I'll make sure we get that asked as well. Yeah. A couple of people are asking about blood tests. Mm-hmm. I don't want to go into anything too specific, so I'll scroll and see what they were. Alison, are your eyes working quicker than mine?
Yes, I can see one that says, can an elevated gamma GT level in a non-drinker be caused by polycystic liver disease?
So an elevated gamma GT in a non-drinker probably means there's a bit of fatty liver. I wouldn't necessarily correlate that with having polycystic liver disease, although that is also possible. So I think I would probably ask them to go and see if, with their GP, to check if they've got fatty liver in the background, if you've got an elevated GGT.
Thank you. Another question that I think is quite interesting is somebody said, do doctors still not know how one gets PLD, or whether it's inherited or how you come to have it?
So polycystic liver disease, if it's occurring in isolation, is an inherited condition. And by that, I mean, it's a genetic condition. And it is also an autosomal dominant mutation, much like polycystic kidney disease. So yes, if a parent had polycystic liver disease, which is isolated, and from a genetic condition, the child may well also develop it. So there are several mutations. I won't go into the intricate names of theirs, but it is a genetic condition.
Thank you.
Thank you. If a patient presents with abdominal discomfort, wouldn't an enlarged liver be found by palpitation?
Yes, so it is possible if you come with abdominal symptoms on palpation. If you've got an enlarged liver, then it should be palpable. But oftentimes, based on the amount of fat tissue you've got on your tummy, it can sometimes be hard to palpate an enlarged liver. So that's when your GP probably would send you for a scan.
Mm-hmm. Now, I'm going to move back to treatment then. I'm going to bring Alison in because I know her eyes have been up and down this as well. Someone who's on hemodialysis, they wonder if they would still be able to have fenestration for PLD, allowing for the fact that they are on hemodialysis treatment at the moment.
Yes, so we just have to time the hemodialysis in such a way that you have your regular hemodialysis, then you're posted for the surgery, you have your surgery done, which usually is typically a day case procedure. You come in, you have your procedure done, and you can go either that evening or the day after, and then you go back to your regular hemodialysis. So being on hemodialysis is not a contraindication. You can have a fenestration procedure if your surgeon thinks that's what you need.
Fantastic. And just when we're talking about medications, if medication shrinks the size of the cyst, does the liver size decrease?
So when the size of the cysts decrease, the total volume of the liver decreases. But the number of your liver cells don't change.
And someone said, I was told I can't keep having deroofing done, but I'm in so much pain. I currently have a 12 centimetre by 9 centimetre cyst, and I'm not sure what the next step would be. I think that would be one for their own consultant, but just in general, can you give us a simple answer there, Aarathi?
So based on the size, I would assume that the cyst can be deroofed unless it's located deep inside the liver. And if it will compromise a vascular structure, trying to deroof it. In that case, maybe, like your surgeon said, it may indeed be unsafe to try and attempt another deroofing. If deroofing doesn't work, your surgeon may try to see if aspiration and sclerotherapy works. But again, oftentimes the problem with aspiration and sclerotherapy is that they fail much more number of times than fenestration does. So again, we may be putting you through a procedure which is not benefiting you. So perhaps at this point in time, just including lifestyle modifications and maybe occasionally taking analgesics, painkillers, if your symptoms are way too much to handle, I think these may be some of the things that you can try. And I would suggest continuing to see your GP or your surgeon.
And again, people are mentioning ultrascans and how often should you have them. Again, Catherine's saying, I've been diagnosed with PLD. How often should I have an ultrasound if I don't have symptoms?
If you don't have symptoms, once you've had, let's say you've been diagnosed with polycystic liver disease, you've had your scan this time around, and you have another scan in a year's time. If it does not show any alarming growth in the cysts and you've got no symptoms, you do not need to be scanned routinely. Unless you think something is different and you're starting to feel a bit of more discomfort, in which case you can go to your GP to get another scan. You don't have to routinely get scanned if you've got no symptoms.
Interesting, this one. I always think of cysts as little balloons that stretch and get bigger. Someone's saying, I have been told that due to my cysts being honeycomb structure, they cannot be deroofed as a lot of bile, as risk of bile into the body. You mentioned that the fluid can be absorbed into the body. Is this a problem for the body when we reabsorb the fluid from cysts?
So if it's a large cyst, then you remove a portion of the wall, and if there is no bile inside it, that fluid can be absorbed back by your body. What happens when we deroof a cyst and we find a bit of bile inside it is that we stitch the area where the bile is leaking. And then whatever fluid that the wall of the cyst is otherwise secreting can be absorbed back into the circulation by your body. With honeycomb cysts, what they essentially are trying to say is that there are multiple small cysts, and it's often harder to de-roof multiple small cysts. They don't benefit. If anything, they, like they said, end up being risky because you probably will inadvertently injure some bile duct, which can then leak bile and lead to more complication.
Now, I'm aware in the chat we have had a question from parents of an ARPKD child. So that's a recessive version, which we all know it's a very rare and extreme version. They've popped a little question in the chat. What I'd like to do, I'll send you privately for answering so as not to confuse the conversation, but it would be lovely
no problem.
if we could answer that. I'll email it to you directly.
That's all right.
However, it's Anne and William. Please can you email info@pkdcharity.co.uk and I will get a direct response to you. When I get that back, I'll certainly get that question over. It's just not to confuse the conversation. I know it's important to you. Alison, we've got a couple of minutes.
Yeah,
the closing one.
Okay. Can I just say we also have, I know we have a consultant who's asking a couple of questions as well. Is it okay if I put him in touch with you afterwards so that he can ask you those questions directly? We'll get that sorted for you. I can see his name, so I'll let him have a conversation with you separately if that's okay. I think just back to something really practical, just two really practical things. Somebody said, I have polycystic kidneys and enlarged livers with cysts. I have a lot of pain on the right side and find bending down really uncomfortable. I haven't had a scan recently, but no, the last time I had one, I had large liver cysts. What can I do?
Go back to your GP, get another scan. If they are large enough, maybe there is a way to de-roof one of them that can then reduce your symptoms.
Thank you. And one more practical. Is there anything I can do to help diaphragm inflammation when I'm breathless due to the size of my liver and kidneys?
Unfortunately, the only way to manage that would be to replace your liver. So there's no way to fully get rid of those symptoms. But I would say that making small changes to your lifestyle, maybe propping yourself up a little bit more, sleeping on a certain, turning to a certain side, if it helps you breathe better. If none of these work, then go back to your surgeon to see if there are any ways that they can reduce the volume of your liver, either medication or surgery.
Thank you. That's great. That's the last of my questions, I think.
I think we're against the clock there, and a huge thank you from PKD Charity and our community. It was a thoroughly enjoyable presentation.